So, since you're all awake still, one thing I have to say in this meeting which is lacking is a lot of interactivity. Right? Everybody is kind of sitting there, absorbing the knowledge, and is quiet. So we want to change that if we can, and make this a little bit more interactive. So I've asked 4 of my colleagues, and myself as well, to put together some cases for you, which we will present and which will hopefully trigger an interactive discussion. So I invite all of you to actively participate in these cases. These should be cases where there is something for the nephrologist as well as for the urologist, where there are questions for the nephrologist as well for the urologist, the typical cases of kind of overlapping problems. So can I have my first case, please? Or first of all, are there any questions to the talk? No, that's all clear?
The series presented at the beginning about the Portugal, and actually there was uric acid going down actually soon, and on the other hand, metabolic syndrome is supposed to grow, all the counters. So this is pretty conflicting.
Well, it's a percentage. I think that the stone disease is,
growing,
as a whole, going up. Probably the uric acid is staying or even going up a little, but calcium oxalate disease is going up further. So if you look as percentage, it probably goes down.
Yeah, maybe an explanation that. Another point is
they
that...
They have Mediterranean diet, which is said to be good.
Actually, we are analyzing the patient on the point of view of the metabolic point of view, both on both sides, urologists and nephrologists, but we don't consider why the patient eats. That's why probably medicine is not a science. It doesn't take an holistic view of the patient.
Yeah,
itself.
Exactly.
So I think that we need to take a look at that too in order to know why. But usually, nobody cares about that in the sense that the people sell, for example, food. Why should they care about the fact that the people eat? So the market actually dominates, and technology dominates the market, but even our minds, and we're reasoning exactly accordingly.
Absolutely. You know, my wife is a nutritional physician, and she tells me what to eat and what not to eat, and I had to scrap about 2/3 of what I like, unfortunately. Doesn't always help, though. Any more questions? Good. Let's go to the first case then. All right. So this is a 61-year-old female patient. She has a history of stones. We don't know what stones. She has bilateral flank pain. She also has a chronic renal failure with a creatinine of 300. She has a high blood pressure. She has a relatively uncontrolled diabetes, and she has a BMI way over 30. Okay, so you get the picture. Now, I asked the audience, what do you see on that X-ray? Yeah, okay, yes. I'm glad the intestine is still there. Anybody sees anything? Take your time. How do you see that? Well, that could be just obesity, right? Yeah. Anyway, let me assure you, you don't see anything on this photo. Okay? So, bilateral flank pain, you don't see anything. You want to do anything about it? Okay, let's have a little discussion here. Why sonography, Kemal, and not a straight for a CT scan? What do you suspect?
Of course, stones could be.
Of course, because
there's
we're in
so many
meeting,
why not? And then when you see the history of stones is also, drew us, and then that's why. And sonography is non-invasive, minimally invasive than CT, and it is to me, it should be a must along with the KUB, and to see if there is any stone, if there is any dilation, anatomy of the kidney, blah blah. It will give us valuable information before CT. That's clear.
So why? Okay, It will, but ultrasound probably will only give you indirect information, right? And you can't see anything on the X-ray. So why not go straight for the CT? Anybody wants to comment on that?
Why not? I mean, why not CT?
Why not go straight for the CT, like Kemal said?
Absolutely no, because, for example, if you want to explore the left kidney, it's difficult to, with the old intestine in front of the kidney. It's going to be difficult, I think, to investigate the left kidney sonographically. This is my point.
Well, that's one point, Kemal. BMI over 30. You will have a hard time to get a good ultrasound on that lady, right? So let's have a show of hand. Who would do an ultrasound? Okay, and who would do a CT scan? Good, that's slightly more. Now, if it comes to CT scan, contrast or no contrast? Why not? Okay, good, good. So you're not that asleep, good. Okay, so we did a CT scan, which gives you this picture. So what do you see? Not always you, let the young guys say something. I know you can see it. So anybody wants to stand up and say what he sees? Horseshoe kidney. Is there something in that kidney or not? Okay, and where's that stone? Where's that stone in a horseshoe kidney? In the center, okay. And now if we take the term center out, is that upper pole or lower pole?
Central stone.
You didn't show that on the guidelines. So where is a horseshoe kidney fused? Huh? Yeah, that's true, but where is that? Up or down?
Down.
Okay, so this stone is in the lower pole, yes. So it's a small lower pole stone. From this we cannot say is it in the right or in the left kidney, right? Of the horseshoe kidney. Or moiety, I should say. Good. What do you see now?
Peripheral stone.
And that's where? Don't say left kidney. So where is it? It's further up in the kidney, right? So either upper middle pole or upper pole, right? So what's that? It's the same CT. It's not a different patient. It's a relatively big stone of 2 centimeters in the upper pole of the right moiety of a horseshoe kidney, right? Do we all agree on that? Good. So we have 2 stones bigger than 1 centimeter in each moiety. We have 1 stone 4 millimeters in the isthmus. We do know now that the stones are radiolucent. Okay, do you want to give any drugs? Do you want to give any alkalization, surgery, or anything else? So let's talk for the drugs. What drugs would you consider to give? I didn't tell you, I didn't put one thing on the slide because I didn't want to give you a clue in the beginning. She has a high uric acid in the blood. That goes without saying, yeah. No, that goes without saying, of course.
I don't know why she has renal failure. That's not obvious right now. I mean, I want to see the, don't you want to see the urinary tract? The collecting system. Because, is she obstructed? I mean, these stones are...
She has pain.
Yeah, so I think before you give her
But
any
no
drugs...
hydronephrosis in that kidney.
Yeah, so I don't think you're going to give her any Flomax, nor, right?
No, not for a
Yeah,
2 centimeter stone.
Yeah,
no.
so I think, the question is whether she has obstruction that's reducing kidney function.
Okay, so
I
from
think-
that CT, we can assume she has no obstruction.
That's, you concluded?
now,
Okay.
right? She might have on and off
So you didn't
obstruction
see
of
any-
these stones moving towards the POJ, right?
Okay. So, I mean, because the question about her kidney function obviously will affect what drugs you give her at this point. Whether you could alkalinize a uric acid stone is, you could probably do that safely, but her creatinine will make you a little concerned about giving her potassium citrate, but she could probably get some sodium citrate more safely. But there's issues that require monitoring. I'd get a renal consult at this point.
That's what I wanted you to say. But,
Excellent.
but of course we didn't. Of course we didn't. So drugs. Anybody would give allopurinol? Yeah,
Uric acid, how high is it?
it's high. I don't know how high it was, but it was high in serum. I just deliberately didn't mention it, so not to give a clue before the CT scan,
I
right?
don't think that's urgent. Ultimately, uric acid may affect kidney function, but that's, I don't think that's an issue at this moment. I think you take care of her stones. Don't worry about her serum uric acid. She doesn't have gout right now. Unless you tell me that her uric acid is, you know, if it's 12 or 13 or something like that, then giving her allopurinol is a reasonable thing. You start at 50 milligrams, a couple of weeks, and then slowly increase the dose.
Well, she solved the problem for you
Okay.
because
So then,
she doesn't tolerate it.
okay, so if you could give her febucostat at this point, if you have that available, that would be a reasonable thing. Obviously, if her uric acid was very high, you could give her a dose of respiricase, which only costs, you know, $80,000 or something.
Oh, only.
That's it.
Good. So allopurinol is out. What's the next step then? So we don't, as you suggest, it's not urgent. We don't, you know, deal with that. So what's the next step? You said it already, so you're not allowed to say it again. No. That wasn't available at the time, by the way. Well, alkalization, right? What do you suspect? You suspect a uric acid stone, right? Or 3 of them, actually.
Why not the contrast study before starting?
Creatinine is 300. Yeah. I suspect, by the way, David, it was a diabetic nephropathy, but
We must do a derivation.
May I say something about the Ansfield unit, for example? We haven't got the Ansfield unit, and second one, the stone is pretty inhomogeneous. It's a kind of a target stone with some
rings,
ring
yeah.
inside.
yeah.
So this is.
But it was not at all visible on X-ray as you had seen, right? So it's purely radiolucent. We don't have the Hounsfield units. Now, as David already mentioned, alkalization can be a problem. Because, as he rightly said, potassium citrate in a creatinine of 300 is probably not a good idea. Now, then David said, let's put sodium citrate.
Yeah, so let me say one thing about sodium load in this patient. You know, there are now studies showing that alkalinization probably is good for preventing the progression of chronic kidney disease. And there are big studies, randomized trials being done to demonstrate that, both in chronic kidney disease generically and in diabetic nephropathy. And most of those studies to date have shown that the sodium is not associated with the hypertension that we associated with sodium chloride. And at this creatinine, I would not be too concerned about the blood pressure. Of course, I have to treat the blood pressure, but giving her sodium citrate is very much safer than giving her sodium chloride, which of course you wouldn't do. But the studies so far in CKD show that sodium citrate or sodium bicarbonate is not associated with the same risk of high blood pressure as sodium chloride.
Of course, being urologists,
No, but I suggest strongly to have some evidence of the urinary tract. I feel it's not prudent to go straight to medical treatment without knowing anything about urinary tract.
well, we didn't, Alberto.
But
I'm discussing the options.
yes, but before treatment, because probably you will find some surprise, and it is better to know it in advance, not after starting treatment. I think it's not prudent.
Okay, we didn't want to give IV contrast for obvious reasons, right? So that leaves us then, if there's no medical treatment at this point, it would leave us with surgery. Right? So who would do open surgery on this patient? Thanks God. Who would do ESWL on this patient? Can you do ESWL on a horseshoe kidney?
Yes, of course.
You can.
But not in this.
Not in this. Why?
Creatinine.
Creatinine and?
I would suggest to rule out any obstruction to make a
Yeah, you're okay. You don't have to repeat what he's saying. I'm with you. I'm with you.
You must put a catheter or something to solve the obstruction. I think it's not correct speaking about treatment without knowing which is the urinary tract.
Okay.
Absolutely.
Anyway, just to complete the picture, in a horseshoe kidney, usually you have a high insertion over ureter. So if you do ESWL, you get residual fragments in a highly recurrent stone disease, which is uric acid stone disease. So the chances that the patient will have residual fragments and grow new stones are increased, and the chances that these fragments will be washed out by the kidney are decreased because of this high insertion of the ureter. Now, who would do URS on this patient? Okay.
Combined treatment.
Who would do, I know for the obstruction, yeah. Who would do PCNL? Only one? 2, 3, 4, 5, 6? You would do. You come to my clinic, you're welcome. Okay. Now, that's what we did, but not only. So we did actually bilateral PCNL in one session, got the patient stone-free. And then we did a percutaneous alkalization to dissolve whatever residual fragments would be in the system with SUBG, which requires, first of all, a very good drainage. So we achieved that with 2 double J stents and a bladder catheter, because you don't want the SUBG, once it has passed the kidney, to stay in the system for any amount of time. In this particular patient, you have to monitor the renal function very carefully and the bicarbonates as well, because of this SUBG. And because she is diabetic and she has all this plastic in her foreign bodies, you need a good antibiotic prophylaxis. Do we all agree on that?
On this treatment? Or about the risk of...
No, if you do this treatment, these things have to be considered. And there was no obstruction.
But you can spare the percutaneous approach by putting a nephrostomy and do a medical treatment.
Yeah, but look, if you put a nephrostomy, then you might as well open the nephrostomy by a few French and put your instrument, right? You may argue now, yeah, local anesthetic versus general anesthetic, and yeah, okay.
Can I ask you about the irrigation? Because you have 2 nephrostomy catheters and you put in the alkaline solution and hope that this will dissolve the fragments and pass through the stents or ureters to the bladder. But there is a high risk if you do this that you increase the pressure into kidneys that already has a reduced renal function. So I would suggest some arrangements so that you had a thin catheter through which you administered the alkaline solution and allowed it to pass out through the rather thick nephrostomy catheter.
Yeah.
But
okay. I mean, for that reason, we put the double J stents and the bladder catheter to
Yeah,
make sure that the fluid can go.
yes, but I
straight
don't
out.
think that the stent is enough.
It's arguable, yes. Yeah.
Why did you do it bilaterally? Would it be more safe for the patient to do the one side in one session and the other side in a second session?
Of course, it would be more. Yeah, go ahead.
And if, considering what we could see from the images that we saw of this specific case, I suppose that the most difficult point to get to through a PCNL tract would be to go to reach the stone that was on the lower pole, the smaller one. Would it be possible to do a complete clearance of the fragments during the session, and the alkalization, the percutaneous alkalization would not be necessary?
We did clear all 3 stones, right? But just in case, because for the reasons that I mentioned before, we would not want to give IV or oral medical treatment, we decided on the SUBG treatment. Now, the reason we did both sides, it would be safer, and it's good clinical practice to do one side first and the other side, but there were good reasons, because if you do this SUBG treatment, you have to first flush the kidney 2 days with saline, and that way we make sure that everything is washed and everything is flowing and there is no high pressure in the kidney, right? And then you follow 3 days of irrigation treatment, plus the 2 or 3 days after the operation until the bleeding stops. So the patient has to be, for each side, 10 days in the hospital. So the reason for this was simply to safer another operation, another 10-day hospital stay.
Nora, I have another good idea. Check the electrolytes again.
Kidney function, that would be included.
Thank you.
Bicarbonates and kidney
You're going to
function.
show us that?
Huh?
You're not going to show us that, though.
No.
That's why you needed a renal consult.
Absolutely. Good. In the interest of time, we need to go on, and I want to invite Robert to present his case now.
Not coming up. Okay, so I'm going to present 2 related cases that touch on something I presented earlier in the meeting. One of them certainly does need some urological support, and the other probably needs some longer-term monitoring. So here's the first case. So I'd like a little bit of audience participation, and they're not too difficult, really. So this is a 40-year-old female who originally from Pakistan, and she was found to be vitamin D deficient and iron deficient. And at another hospital, she was given a diagnosis of celiac disease. And this actually was confirmed by jejunal biopsy in 2012. And actually at that time, around that time, because she had a CT as part of her workup, they noticed that she had bilateral stones. They didn't really do anything about that at the time. This was simply noted as an incidental finding when they made the diagnosis. And then she presented about a couple of years later, I think it was about 2014, or actually 2016, with renal colic. This required an intervention. I think one of the stones had dropped. And this stone was found to be 100% calcium phosphate. And as I say, it was removed at URS on one side. So she was still left with another stone, a small stone. And this was some subsequent biochemistry which was done. So she was noted to have a low potassium, 3.3, and she was found to be ANA positive. She had a bicarbonate of 16. She was also anti-Ro positive. She had a chloride of 108, which is slightly elevated. She was anti-La positive. And she had a GFR of 50, an estimated GFR of 52. And on closer questioning, she gave some symptoms, particularly reporting dry eyes, mouth, and she was noted to have quite widespread vitiligo. This was her total IgG. She did have a protein electrophoretic strip, and it was polyclonal, and her urinary citrate was very low, almost undetectable. She had an elevated urinary RBP, that's low molecular weight proteinuria. Nothing obvious on the dipstick other than that. And as I say, it wasn't detected on the dipstick, had to be looked for. So, what about the diagnosis in the context of the calcium phosphate stone? So, Younger members of the audience? So what could this be an example of? Younger members of the audience, Philippe.
Wishful thinking.
Okay, so more generally. So this would be an example of autoimmune distal RTA. Actually, it's probably got a mixed phenotype, as we discussed earlier, because she has tubular proteinuria, which would not be a typical feature of distal-only RTA. So that was that case. So here's a second case, a little bit different. So this is more a medical case. So again, this is an Indo-Asian female, a bit older. She was complaining of worsening muscle weakness and lethargy, and she reported to a general physician and was found to have a low potassium at 3. She was told to eat more oranges and bananas, and this only had a slight effect. Potassium went up to 3.2. So she returned later following an episode of diarrhea while on holiday, and she became markedly hypokalemic, potassium of 2.4, and she had persistent loose stool. She gave a family history at that time of colon cancer, and this prompted an urgent colonoscopy, and she was found to have a villous adenoma. So you might stop there. You might think that's a sufficient explanation. This led to a partial colectomy, from which she made a good recovery, though requiring intravenous potassium supplements pre- and post-surgery, and she was discharged on all potassium supplements only. So that's it at this point. Now, she was seen 6 weeks later, post-surgically, in the general surgical clinic. She was still on potassium supplementation as KCL. She was still feeling generally unwell, although no loose stool or diarrhea. She was now complaining of some aching joints and stiffness and muscle weakness, sore eyes and dry mouth. And there was no family history other than the colon cancer, as I mentioned. And before I go on, is anyone going to predict the blood chemistry? Okay, right, I'll go on time. So this is their chemistry. So creatinine is slightly elevated, 110. The abnormal findings are in red. Potassium of 3.2 still, so she's hypokalemic. Low normal bicarbonate, 22. Slightly raised chloride again. Total protein of 90. PTH very slightly elevated at 12. Calcium is probably, corrected calcium is a little bit on the low side, but it's within normal range. Low phosphate, 0.6. ESR of 40. GFR again of 50. Urine dipsticks 2+ protein. Normal anion gap. Anything at this point from anyone? Younger members, please. Okay. So these are the further blood tests. She had a high rheumatoid factor titer. She was also ANA positive. She was extractable nuclear antigen positive, rather like the previous case. She had an elevated IgG, which was polyclonal. That's the strip shown on the right. But her DNA, double-stranded DNA, and her complement were all normal. She was ANCA negative. Her spot urine, so she had, that was her urine pH, spot urine pH. That was her estimated fractional excretion of potassium, which is high. Sodium and potassium in the urine, chloride, calcium low, citrate very low, and using Bill Robertson's, we actually had 24-hour urines on this patient. This is what we got as a predicted calcium phosphate stone risk in her. That was her renal biopsy. Any comments? So it shows an interstitial infiltrate, so tubular interstitial disease. She actually then, she confirmed she had tubular proteinuria as well, like the previous case. So plain X-ray, however. So she doesn't have anything to see. So she presented medically. Obviously, she was looked at from the stone point of view. She had no stone symptoms, but it's just to make the point that these patients can have the clinical phenotype, but don't necessarily all have stones. That's really from the old literature, showing that these patients typically have autoantibodies directed against the collecting duct, shown here from an old publication in 1970. And this is a study in the early 1990s, taking serum from a patient with autoimmune thyroiditis and putting that serum onto rabbit kidney and showing that it's binding. There are certainly some epitopes that it binds to in the collecting duct. So again, just showing these circulating autoantibodies. And that's again fairly typical. You can sometimes see calcium deposits in these patients. again, publication in 1991. And again, that will be often the sort of thing you might see. It's another example of DRTA with stones and nephrocalcinosis. So again, I just wanted to emphasize that this is not an uncommon presentation. So in an adult clinic, autoimmune DRTA is not unusual. In some reports, anything up to 20% or so of patients with Sjogren's syndrome will have the phenotype of DRTA. But it applies to all forms of autoimmune disease, including even in HIV with polyclonal gammopathies. These patients can have the same presentation. So the messages are incomplete DRTA, as I've mentioned before. The incomplete, the plasma chloride and bicarbonate are often within the normal range, but hypoclemia can be a useful clue, or low normal potassium. Family history, again, we know that about 40%, as we heard on the first day, 40% of patients with stones have a family history, and that family history could include those patients with particularly autosomal dominant distal RTA, and they're not so unusual. Calcium phosphate stone is an important clue to think about, to follow up, to exclude, and you can use either the frusemide and fluorocortisone test I mentioned, or perhaps even Bernie Hess's modified ammonium chloride test, which in some ways might be more reliable and better tolerated. Autoimmune disease is a common link to DRTA, although you don't always see nephrocalcinosis or stones in these patients. Low urinary citrate is another very important clue and highly suggestive. And I just want to say a comment in relation to what we've been hearing about the use of alkali therapy and the risks or not for stone formation. I think it's very important that the alkali is delivered as potassium, as you saw earlier. I think the evidence is, certainly from Bill Robertson's data, that if we give it as sodium bicarbonate, we might actually worsen the risk of stone formation, not actually deliver enough citrate to offset the small pH change that we saw that David had shown previously. So it's the citrate that's the key, and I think it needs to be as a potassium salt. And as I mentioned in my own talk about thinking around bones and thinking around DRTA. And of course, such patients, I think, particularly that second case, would need to be followed in a nephrology clinic, particularly with a degree of renal impairment, but certainly in anticipation of problems in the longer term with a urologist in mind. So I just wanted to end on one point in relation to citrate.
Can I ask you a
Go on,
question?
please.
You said something about diagnosing RTA
Yeah.
and doing a certification test in the presence of CKD.
So yes, so if you look at Oliver Wrong's original data in 1959, he actually looked at CKD, and he was able to show that these patients acidify normally. So with the ammonium chloride test, they acidify normally. I can't say the same for the FNF test. We haven't tested in that context, but certainly ammonium chloride testing, you'll get a normal response in patients with renal impairment, so that doesn't confound the test. So thank you for raising that.
So when I think of this, I always think of tubular dysfunction in excess of any glomerular dysfunction. So as the creatinine goes up, making that distinction becomes exceedingly and progressively more difficult, I would think.
I think that is true, although again, based on Oliver's work, early work, when he particularly looked at quite a large number of patients with CKD at different levels of EGFR, he was able to show with the ammonium chloride test that they all responded, could acidify their urine to what he set was his threshold of 5.3 ultimately, but that his RTA patients couldn't do that. That was really it. So it doesn't seem to be a confounder. And just my last point, just to make in relation to citrate handling, which I think is just worth mentioning, is that when you give citrate acutely, you will see a small increase in citrate excretion. When you give it chronically, much of it is metabolized to bicarbonate, so it's really alkali that you're giving. And in fact, the amount of citrate that you boost by orals, given the typical amounts that we give, is actually very modest. So, you know, it's actually, and my own experience in DRTA, particularly in the complete form, it's very difficult to boost their citrate excretion with oral citrate. So, you know, theoretically, it would be very interesting to target directly the citrate transporter. And in theory, you could very significantly increase citrate excretion if you could block citrate reabsorption directly. So that might be a therapeutic strategy of the future. And I think that would be of wider benefit because it's so inconsistent sometimes in trying to give patients adequate amounts of oral citrate. I fully support that, but it's just often practically quite difficult in some patients. So I'll stop there. Thanks.
Thank you, Robert.
Okay, I would like to invite Kemal to present his case.
Hi again. I know you're really tired for lunch, and then I'm going to present a case, a pediatric case. First of all, I should tell that I got the information or the format of the presentation at the latest period, and then I thought about it. What should I do in order to give some relevant information? And then, as we have lots of kids treated for stones, I refer to our pediatric nephrologist, and together with her, although some data may be missed, sorry for that, in advance, I tell you, I brought this case and in order to give some certain information, clues in the management of stones in kids. Let's begin. This was a 6 years old boy. He referred with left flank pain and hematuria. Family history of stones, as you see here, father, mother, and cousin, common in my country at least, positive family history. Known right renal agenesis, that means solitary functioning kidney, and history of Anderson testis treated in early childhood. No history of UTI. And here, the KUB shows us a left stone in single functioning kidney. And because of that stone, case referred to us to the urology department, and he was treated with shockwave lithotripsy with JJ stent in situ. This was the, sorry for that, this was the KUB 4 weeks after shockwave lithotripsy. As you see, a majority of the stones have been treated and the kid has passed them. But however, he had some residual fragments left in single functioning kidney that should be seriously taken into account, as you may appreciate. And this is the image after 3 months post-shockwave lithotripsy. Small fragment in the left kidney in lower calyceal position. Residual fragments in the solitary functioning kidney in this particular child has been treated with ureteroscopy in order to render him stone-free. And sonography after 6 months showed no stone detectable, no dilatation, normal kidney size, shape. The kid was symptom-free. And we discussed the issue with pediatric nephrology department and our pediatric nephrologist. She evaluated the case in detail, and as you see here, performed the necessary relevant evaluation. She performed, and as you see here, 24-hour urine analysis data was the parameters from her aspect was in normal limits in all parameters evaluated. The stone analysis derived from the retrograde internal surgery, as you see here, it revealed the stone composition to be calcium-containing stone, both calcium oxalate dihydrate and monohydrate stone. And depending on the particular situation of this child, our pediatric nephrologist, in collaboration with us, she went further with the treatment, and in an attempt to limit new stone formation and to ease the passage of maybe relevant, undetectable, very tiny, small residual fragments, to ease the spontaneous passage of them, she applied medical management by giving potassium, sodium hydrogen citrate. Parents were really cooperative along with the child himself. And as you see here, during the follow-up period, the child was really free of stones with no symptoms, no dilatation, particularly related with the solitary functioning kidney. The key message from our side could be the early onset of stone disease and strong family history. We have these cases in our country, pediatric cases to a certain extent. This really requires a true metabolic evaluation in a close, well-established collaboration with pediatric nephrologist. Family needs to be involved and informed to obtain a good compliance. It's very difficult, we know. Important issue. And concerning the management of stones, we should be as minimal invasive as possible by considering shock value lithotripsy always, if possible, in the first place, in all children. We know that it is effective and relatively larger stones can be treated well, and the kids, they pass the fragments very effectively in a shorter period of time when compared with adults. For that reason, we should apply minimally invasive therapy alternatives in conjunction with metabolic treatment, again in collaboration with pediatric nephrologists. Thank you so much. And, if there is any question or contribution on the floor.
Anybody wants to ask anything or comment on something?
You see, very clear.
Everybody would have given citrate in a calcium monohydrate dehydrate stone in a 5-year-old, a 6-year-old.
Investigate a little family, maybe, because it's pretty unusual for a young guy like he was to have nothing in a metabolic study. So I investigated even the family maybe could be a possibility, because it's difficult to believe that.
Stones,
yeah, it's 4 stones, aggressive, active disease, and dumped by citrate, just by citrate. I don't know, it's pretty unusual behavior.
Okay,
Thank you so much.
So then I invite our friend Alberto, please, to present his case.
At least, but not last, nor asked me to be very fast. So sorry.
You're fine. You have 10
You're fine. I have 10 minutes. Okay, thank you. You changed your mind, and okay. It's not working. Okay. What happened? What is the case? A young man in healthy condition. He had a terrible motorcycle accident, and he had 2 problems. The first, he had a damage, a mesenteric injury, resulting in ischemic bowel, and he had a very huge recession of the ileum. And the second, he had a lesion of the ureter. It was not possible to manage it in the surgery, and the surgeon decided for nephrectomy. So, first point, was nephrectomy a good option for this patient? The common opinion in many urologists is that the second kidney is a spare part. So, if you remove a kidney, nothing happens. Because why? Because creatinine remains constant, no increase of creatinine, and you have not dialytic treatment, so no problem. And you see in a very eminent journal of urology, there is this conclusion: renal function remains adequate for patients who have a normal contralateral kidney. I think that this point should be a little bit discussed. Is the serum creatinine a good mean for measuring renal function? And second, is a partial reduction of renal function, also not requiring replacement treatment, harmful for the health? This point are well known by nephrologists. And I think the audience, all the audience thinks that serum creatinine is a good mean for evaluation of renal function. I guess not. I think it is a.
Yes, ask for sure.
No, I think probably some urologists. But we know that serum creatinine depends on gender, on race, on muscle mass, and that we must rely on our measurement of renal function, such as estimated glomerular function. And the second point, we know that after nephrectomy, even in the patient that have normal serum creatinine, there is a decrease of estimated glomerular filtration that is a moderate chronic kidney disease, and even a chronic kidney disease in a moderate chronic kidney disease can cause mortality, an increase in mortality because of vascular diseases, and also can cause a high burden of health problems. And this paper is a paper of nephrologists that clearly demonstrate what I have seen. So the first point was, if it's possible, you should avoid nephrectomy in any case. This is a message that nephrology should pass to urologists. And in the case, it was possible to find a solution to spare the kidney, because in the emergency department, you can close the ureter, and someday after you can put a nephrostomy and defer the treatment. It's nothing difficult to close a ureter. It takes 10 minutes, it takes 1 minute, and after that, you can plan the surgery. And in the specific case, it was very difficult to find a solution because he has no ileum for ileal replacement. The lesion was very high, and so probably autotransplantation was the only option for this case. But you must spare the kidney in any case. Second point, after ileal resection, nobody explained to this patient that he could have some problem of the metabolism. They said, eat a lot because you are a malabsorber, you have to recover your shape, and they had eat a lot, but after 3 months, he produced the first stone. And after that, he continues for 9 years to produce stone, and nobody explained him that he has to do something to stop this. And no metabolic study, no prophylactic treatment, only an increase of fluid intake. We know what happened. We discussed it in the previous day, and we know that hyperoxaluria and decreased urinary volume are the two most important problems. At the very end, this patient had a dramatic consequence, because after repeated procedure, he had a lesion of the ureter, of the left ureter. And the urologist decided to have a minimally invasive approach in these patients. And my feeling is, the bigger the problem, the bigger your surgery, because if you try minimal approach in a patient that has a big problem, sometimes you can do worse. And they put a stent, a metallic stent. The stent was encrusted because he was doing no prophylaxis. And at the very end, he arrived to our clinic in renal insufficiency with sepsis, and we have to put a nephrostomy. And after that, we have to reconstruct the ureter with a psoas procedure. And on the other hand, nephrologist started a treatment to prevent subsequent production of new stones. So in this case, the combined approach of urologists and nephrologists was crucial in order to solve the problem of this very, very, very difficult patient. And so I think that this cooperation will be increased, and I think that as a neurologist, please, I cannot comply with the picture, but probably some other in the audience, but I promise that for the next meeting, I will be in perfect shape as in this picture.
Okay, now we go straight to the last case, please, which is my second case. Yeah. So a 17-year-old girl presented in the emergency department with a right-sided colic. It was the first ever occurrence of such a colic. No comorbidities in her medical history whatsoever. No medical, surgical, or urological history. And no metabolic syndrome. She's slim. So what do you suspect? Huh? I can't hear that. Well, just make it stone. Just make it stone. Okay, so when we investigated in the urine, there is only a little bit of blood. The rest was normal. Full blood count, creatinine, electrolytes, CRP, normal. And when we gave her a little bit of morphine, everything settled down. So what is the next step? Morphine for the surgeon.
Why did you give it more?
Huh?
Why did you give
Oh, because she had severe colic and she didn't respond to other things.
no sonography again? You have no idea. You don't like sonography.
Well, we go, see, we have a CT scan in our accident.
This is unacceptable. This is not acceptable.
It's a low dose.
Even if low dose or minimal dose, no dose, sonography we should need.
Okay, to my excuse, I have to say when I came, the CT was done, okay?
That's acceptable.
It was done by the emergency doctors because they do it in every flank colic, right? That's actually not what I wanted to discuss, but I can partially agree with you, yes. So she had a 4-millimeter stone in the VOJ, just before the bladder. So what would be the appropriate treatment? Yeah? Yeah, it's a conservative treatment, right? Okay. So we did give her tamsulosin and painkillers. We instructed her to drink and move around. And we gave her a little strainer to catch the stone if it comes out. We instructed her to look out for the stone, right? So 3 days later, I saw her in my clinic. The clinical symptoms had settled. She didn't need any more painkillers. The hematuria, the microhematuria, was no longer there. I did an ultrasound, finally, not a second CT, which showed no more obstruction on that kidney. Thank you. And she brought me a little stone, 4 to 5 millimeters, which she found after voiding in the toilet bowl. So I sent that stone off for analysis. So now I need the help of the nephrologist to tell me what this is. Anybody has any idea? Yeah? Huh?
Is it actually the stone?
I think that it's not the real stone, but maybe something from the toilet bowl.
Actually, I asked her back to my clinic and I interviewed her a little bit, and it turned out that at that time they had repair works done in the bathroom. And she found a little stone. So I thought with this case we finish the session. I thank you all very much for your attention. And I will, you want to have a last word here, please? Yes. Yeah, please come.
Yes, the last talk, the last word is to the presidents of the meeting, and we are very happy of this of your participation, because we think that there were different levels of appreciation of this course, and at least it is what we are feeling speaking with you. But we also, so thank you very much for coming and for the interaction and for the interest. And since we would like probably to repeat this experience perhaps in 2 years' time, especially to the participants, to the small groups, we are going to ask their opinion with questionnaires that will be mailed in the next few days. So please answer, give concerns, critics, suggestions, comments, just to improve the interaction. Because we think that the interaction is very important, and we may do better work for us and for the patient. Thank you very much again.